Alright, so welcome back to another Con Ed class here from my office. Today, this video is half an hour, roughly, on OB emergencies, obstetric gynecologic emergencies. It's hard to do this in just half an hour because I kind of feel that it's hard to cover everything. So the first thing we're going to talk about is a little anatomy. And you've got to think about male versus female because the urinary system's basically the same. I mean, the outlet's a little different, right? I mean, you've got two kidneys, hopefully, two ureters. So the kidneys, ureters, down to the bladder, down through the urethra to the meatus. And of course, the meatus in the males and females are different. If you don't know that, go Google it. Anyways. But that's where we run into this difference, males versus females, right? So for a male who has an abdominal issue or abdominal pain, it's fairly cut and dry. It's either vascular, muscular, muscle wall, for example, abdominal wall, intestinal, or urinary in nature. Of course, there's trauma with, skeletal. But females have all that. Plus, on top of that, they have their gynecologic system. So, just a couple of short pictures of this to show. And this shows why females, for example, pregnant females, they always have to pee, right? They have urinary frequency and they don't go a lot. Because this cervix sits right on top of the bladder, okay? And a good picture of that is this. We look at the baby, pretty much full term by the looks of it. Placenta on top, baby head down against the cervical opening, and it's squishing that bladder into this tiny little hole, okay? So, or tiny little cavity. Which is squished between the symphysis pubis, part of the pelvis, and the head of the baby. Now, I'm not an artist by any means. If you've taken a class with me before, you know that. But I feel that if I draw things myself, as ugly as it may be, it helps me remember things. And it helps me be able to visualize it better because I've done it by hand. And it's a fairly accurate portrayal, mind you. So, again, not necessarily to scale, but vaginal opening, vaginal vault, cervix. So the uterus is this kind of smallish, very muscular organ. And this organ has lining, the endometrium, which is where, the mom is set up for the baby to attach, the placenta to attach, and the baby to grow. Cervix is the opening to the uterus. We have our fallopian tubes, and we have our ovaries. Now, why did I draw this as kind of an opening with little feelers, and then the ovaries? Aren't the ovaries attached to the end of the fallopian tubes? No, they're not. And this can lead to one of the issues with some tubal pregnancies and problems with pregnancies that we'll get into in a little bit. So what I want everyone to kind of understand, and women know most of this, guys don't always understand how this works. We just know that women have cycles, they have periods, they bleed. Other than that, we're kind of clueless about it for the most part. So a cycle is And when the books say the cycle is 28 days, that is mostly accurate. But you have to remember, humans are different. Each human is a little bit different from the next one. And so when we say it's 28 days, some women are absolutely 28 days. And some are 26 this month, 33 next month. They may be on forms of birth control or hormonal therapy, and they might go 4 months in between cycles, okay? So, but by textbook definition, it's 28 days. Day 1 is when the cycle starts, when they start to bleed, when they start to have the menses, the period. This lasts about 5 days. Again, everybody can be a little different. And we think of all this blood. The reality is the average cycle, the average period itself, there's only about 30 mLs of blood, 30 milliliters of blood. That's 2 tablespoons, right? A tablespoon is 15 mLs. So it looks like a lot. I mean, if I bled every month, I'd probably think it was a lot too. But roughly 2 tablespoons of blood over that 5-day period. And women know how many pads or tampons they use during a typical day. So one of the things we can do with a female who has a complaint of bleeding is, hey, first off, when was your last period, right? 4 weeks ago. Okay, so it's time now, right? Yes. Are you late for your period? Are you early for your period? Does this make no sense at all in relationship to your period? And how many pads or tampons have you gone through today so far? Right now it's almost 11 o'clock in the morning. I've gone through 3 pads. Well, okay. How many pads do you normally go through in a day? And if the answer is 4 pads in a whole day, we know this is more than normal. So that would be something we'd worry about. Now at day 14 is ovulation. The ova is released from the ovary, flows through this little gap up into the fallopian tube, where typically the sperm meets it and it becomes an ovum, and it then travels into the uterus and attaches to the uterine wall. Now, what's happening in that 2-week period, day 5 to day 14, is that this wall is starting to thicken again, okay? And that wall thickens to provide that attachment point and that source of genetic material and food and whatnot for that ovum to attach. So if this egg is released and there's no fertilization, the body recognizes over the next 2 weeks that this did not occur. And then it starts to slough off that extra tissue, and day 1 starts all over again with our cycle. Now, menarche, which is the start of a period, is roughly at the age of 12 years old. Can be a little earlier, can be a little later. And menopause, where women switch over and stop having periods, is the average age of 51 years old. Now, some of the things we get called for, pain and bleeding, are probably the biggest things. So what are some causes for pain for this? Ovulation. Women have pain and cramping. The technical term for this, middle schmerz. They can have cysts. So on the ovary, they can have a cyst, pocket of pus. They can have one on the fallopian tube. And if you think about the size of these tubes and the size of the ovaries, it doesn't take a lot of effort or a lot of increase in size to cause this pain. Endometriosis. So the endometrium, the lining of the wall, is a chronic condition that women tend to have, and it's kind of like having the period from hell all the time, right? So they have a lot of this thickening of the wall, a lot of sloughing of material. They have heavier than normal periods. They have abnormal periods. They have a lot of pain that goes with this. Now, endometritis, I said that right, is an acute event. And that is, you think about your terminology for medicine, itis is inflammation. So inflammation of the endometrium, and it tends to be an acute event. So chronic is over time, acute is an onset. And this can be caused by infection, it can be caused by trauma. Now, ectopic pregnancies. You have the ova coming up here. It gets fertilized by the sperm, and it attaches to the inside of the fallopian tube. Again, these fallopian tubes are very small. So roughly a month after fertilization, they start to have pain. So it's about 6 months since their last period. When was your last period? 6 weeks, not 6 months, 6 weeks. So about 6 weeks ago, well, right, they have their ovulation at day 14. So a month after that, this ovum is too big for the space, and it's causing pain. Okay. You can also have what's called PID, pelvic inflammatory disease. So typically caused by an STI or an STD, depending on your age. A couple of years ago, I was teaching an EMT class in high school, and when I said STD, sexually transmitted disease, they didn't know what I was talking about. I said VD, they didn't know what I was talking about, venereal disease. STI is their term, sexually transmitted infection. I guess disease makes it sound worse. I don't know. Anyways, this is an STI that is kind of out of control at this point, and it's caused a lot of inflammation and a lot of pain. And pain on palpation. A lot of STIs for females are painless. That's the problem until they get out of control. And what you'll see is this thing called the Pid Shuffle. And that's where women stand. They hold their bellies, they hold their lower abdomens in, and they just kind of shuffle slowly, because the bouncing that takes place, the movement that takes place with walking, significantly increases their pain. So they'll hold their abdomen in, and they'll shuffle small footsteps. You can see it a mile away. I mean, I've been in Walmart walking up the aisle towards the pharmacy and seeing the shuffle. Okay, it's not necessarily STI related, but typically. And of course, assault. And assault slash trauma. Okay, so an assault on their organs, whether it be a sexual assault, an assault with a baseball bat, a stick, whatever, internal assault and external assault. It can be seat belts. It can be a punch or a kick. Okay, so those are all things that cause pain, and we need to do a good history on this, right? You think about history of the present illness, sample OPQRST, right? So OPQRST onset. What were you doing when this started? I was getting the shit kicked out of me. Okay. P, provocations, right? Does anything make it worse? Well, also think about better or worse. Does anything make it worse? Does anything make it better? Quality, describe the pain to me. Describe the symptoms you're having. Is it pain, tearing, burning? Do you have bleeding with it? Okay. Does this pain, burning, tearing go any place for R, radiation? Severity, scale of 1 to 10. 10 is the worst pain you can imagine, like I'm torturing you. Give me a number. And then time, T. What time did it start? Did it just start, or has it been going on over a month and getting gradually worse? Okay. So those are all things you have to ask so that you can kind of start to put these pieces together. And again, are you bleeding? Do you have a discharge? So bleeding, does it look like your periods? How many pads of tampons are you going through? Or is it discharge? Is it a different color? Does it have a smell or odor to it? Okay, those are questions you want to ask. Now, causes of bleeding can be those things we just talked about, right? But we can also just what's called dysmenorrhea, just an abnormal period. Endometriosis, of course, is kind of the worst one. But we can have pregnancy issues causing bleeding. So we have our placenta. It's attached here to our baby. Again, not to scale, but if you have a traumatic event, you can pull or tear this placenta off the uterine wall a little bit. And now, remember, the uterine wall and the placenta is where all this exchange of blood goes. So now if you've got this tear, you end up with that blood crossing back and forth, trying to cross back and forth, but it can't because there's a gap, so you get bleeding associated with it. Now, abruptio placenta. Because the other one is called Placenta Previa, and Placenta Previa is where the placenta is just covering part of or the entire cervical opening. There's no trauma involved, and so there's no pain involved. Abruptio placenta, dark red blood, a lot of pain. Placenta Previa, bright red blood, no pain. So the way, when I was in EMT, the way I remembered it is trauma, abruptio. Abruptio is a kind of, in my mind, it's a hard word. It's a coarse word. Versus placenta previa. Previa flows easy. No pain involved in that word. And previa means kind of prior. Previa, So that's the way I keep track of it. So obviously those things. And that you should kind of be able to figure out with your history of the present illness. What were you doing when this started? I was in a motor vehicle accident. I fell down a couple of steps. My sister-in-law threw me off the arm of a couch. Yes, I have seen that. And remember, with some of these questionings, age is going to play a part in it, because this one that got bounced off the arm of a couch was 12 years old, 8 months pregnant, with her second child. She was 15 years old, I'm sorry, with her second child. So she had her first one at 12. So just because she's had prior pregnancies and prior babies does not mean that she is an adult and understands things as an adult does, okay? There's still, like with her, there's still a little bit of this emotional innocence going on around all this. Anyways, treatment for all of these things is mostly supportive. Now, obviously with sexual assault, it would be best to have a female ask these questions and be the one to put hands on, unless it was a female that did the assaulting, of course. But these women don't want to be touched, is what the book says. The folks that I've dealt with, the women I've dealt with who've been sexually assaulted, I go into it with the attitude and telling them, hey, I know I'm a guy, I've got to ask you a few questions. It would be best if I could do at least a little bit of an exam with a little poke and push, but I'm not gonna push it. I'm not gonna push you to do this. When we're just talking, I'm gonna sit way over here, and I will sit as far down the squad bench as I can get from them. If I make you uncomfortable, please let me know. And most of them at that point know that I've got their best interest in mind, and that I'm going to be as emotionally and physically gentle as I can be. And I've never really had anybody refuse. Now, I do not there have been times where I have had to look to see if there's bleeding, and there have been times where I've gone, no. I mean, because I can look at their blue genes and see if they've got bloody genes, right? I can also ask them, are you bleeding? Have you had any bleeding? And then I go with those same typical questions. If there is blood on their genes, if it's spotting just a little bit, I'm gonna be okay with that. But if there's bleeding, then hey, we've got to take a look, because it could be external, and it could be something that we need to put a dressing on or some quick clot on. If it's severe bleeding, I will ask, but keep that in mind. They may refuse, and they have that right to refuse. All right. Now here's and the other thing I think about while I'm taking care of them is they were just sexually assaulted, physically assaulted, sexually assaulted, right? Which is also an emotional assault. When they go to the ER, they're going to have a sexual assault kit done, which used to be called a rape kit. And it is an intrusive, physically intrusive exam as well. Okay, so they're about to go through kind of this all over again. What does one of these kits involve? So they have to stand on a big paper sheet, basically, get completely undressed, all their clothes go into a paper bag, and then any hair they have on their body, pubic hair, underarm hair, leg hair, head hair, gets combed, because what we're looking for is somebody else's hair. Okay. Then any opening in your body gets basically a Q-tip. It might be a small Q-tip, it might be a large Q-tip. And again, we're looking for DNA. Ears, nose, mouth, vagina, rectum, everything. Okay. So then, of course, they want to do vital signs and all that. And we want to do vital signs too. But before I touch them, even for a blood pressure, hey, I'd like to get a blood pressure. Is it okay if I put this on your arm? I'd like to check your pulse. Is it okay if I feel your wrist? I'd like to put this oxygen probe on your finger. Is that okay? So I always ask permission. Right? But treatment is mostly supportive. You're an AEMT or a medic and they're shocky, then hey, I'd like to give you some IV fluid. Is that okay? Otherwise, just make position of comfort and transport. Okay. Now let's talk about pregnancy for a couple minutes, and we're not going to go into the delivery because that's childbirth. This is we don't have enough time for that. But definition: pregnancy 0 to 60 days. Spot, as I like to call them. Whoops. Hopefully, spot's down here. Is an embryo. From 60 days to birth, he's a fetus. Right. From birth to 1 month, neonate. 1 month to 1 year, an infant. Now, normal gestational period, right? So the normal term of carrying is 37 to 41 weeks. We say, oh, it's 40 weeks. Very normal, very typical is 37 to 41. That's considered normal as far as what we worry about with childbirth. Broken down into 13-week trimesters. Now, at full term, the babies are typically 3 to 3.5 kilos, which is 6.6 pounds to 7.7 pounds. All told, between the fluid and the baby, that uterus may be carrying up to 20 pounds worth of weight. That increase in uterine size throws moms back out of kilter, right? So moms have a lot of back pain with this. They have a lot of pain in their pelvis. The pelvis is starting to spread out a little bit to make room for the baby and make room for delivery. Breast size increases, right? Because they have lactation, right? So breastfeeding. And that throws their center of gravity off also and pulls on their chest wall and causes pain. And they also tend to have an increase in sprains and joint injuries. Why? Their center of gravity's off. They can't see their feet as they get to full term in a lot of cases. And they step wrong, they twist their ankles, things like that. And they have more weight pulling on them, okay? What are some of the other changes that we see? So, blood volume. Depending on who and what you read, mom's blood volume will increase between 35 to 50%. Heart rate will increase 10 to 15 beats per minute. This allows a pregnant mom to compensate really well. So pregnant mom is a trauma patient. Pregnant mom is bleeding. Pregnant mom has had horrific morning sickness and is can't hold anything down and isn't drinking and is severely dehydrated. But because of that extra increasing blood volume over that term of pregnancy and the increase in heart rate, they compensate really well. You've got to have a huge index of suspicion about these folks, okay? And, you know, you got questions or doubts, then just be an advocate. Take them to the right facility, okay? The other thing is their oxygen demand increases 20% between their physiological changes and the growth of the fetus. I showed you that picture where it's pushing down on the bladder. It also pushes up on all the abdominal organs, and the abdominal organs push up on the diaphragm, which pushes up on the lungs. So they have a lower tidal volume, the amount of air that they can bring in and take out. So their respiratory rate's going to be a little faster. They may not be able to sleep well. If they lay flat on their back, don't forget that that baby and the weight of the uterus sits on the vena cava, and you have supine hypotension syndrome, right? So we should have them tipped up on their side a little bit. But also if they lay flat, all that weight pushes up on their diaphragm and they have a little trouble breathing, okay? Their GI system, because of all that displacement, slows down. Constipation is a huge problem for these folks. It also, if you remember that picture, besides pushing down on the uterus, it also pushes down on the rectal vault. And that's why, as they're having a contraction and the baby's head is starting to present, it triggers the pressure sensors in the rectum, and they think, oh, and they'll, I gotta shit, and they run for the bathroom. We pull babies out of toilets on a fairly regular basis, okay? Because they don't know any better. The moms don't know any better. Big peri-delivery problems. So later on, that last trimester, we start to get concerned about what's called Pre-Eclampsia and Eclampsia. Old school term for this is a toxemia of pregnancy. Old school term like in the 80s. But so pre-eclampsia, they start to have a lot of swelling. And this is fast onset, like over a couple of days to a week. They have a lot of swelling, their feet, their ankles, their lower legs. Their sacral edema increases. The sacrum, right, lower part of your pelvis. So if you think I'm going to look at any female, much less a pregnant female, and go, so tell me, is your ass always this big? Ain't going to happen. Okay? But I'll ask them, so where have you noticed this swelling? Okay? They'll also have a lot of edema in their face and neck. They'll have a huge weight gain, mostly due to all this third spacing of fluid. They might put on 10 or 15 pounds in a couple of days. All this extra fluid and with their vasculature causes headaches, severe headaches, and you'll start to see the blood pressure climb. They go to their doc's office, they'll dip their urine, and if they've got protein in the urine, pre-eclampsia. So most of these folks end up home on bed rest, and they're trying to just get this baby out to that 37-week area. But if this gets worse, they're at risk for eclampsia. Now, pre-eclampsia to eclampsia, that defining moment is a seizure. And that seizure will not stop with your benzodiazepines, your Verseds, and your Ativans. They need mag sulfate.